All right, good evening. Welcome to this group discussion on divarication in large ventral hernias. I had included, as I mentioned earlier, parastomal hernias, but there's quite a lot to discuss. And so we want to finish well within an hour if possible. And so I've stuck to these two. Pardon me, I'll have to mute myself and deal with this. My apologies. This is one problem. I also have a dog who's going to bark and disturb you. I'm sorry about that, but this is one problem with online meetings. Okay, yeah. Anyway, so we will now to deal with parastomal hernias in a different class. Okay, so when we talk about anything in the abdominal wall, I think the most important thing is to understand the basic anatomy of the anterior abdominal wall. Okay, so we'll involve the youngsters in this. Malavika, sorry, we'll just wait for a second. Wait for a sec. There's somebody at the door and it's causing trouble. Sorry about this. Okay, so we'll tolerate this disturbance for a bit. Malavika, tell me, what is your concept or understanding of the anterior abdominal wall anatomy in relation to a hernia?
Sir, anterior abdominal wall has layers including the skin, there is a subcutaneous tissue, the fascia campus and the scarpus fascia,
Yeah.
and the muscles, the external oblique, the internal oblique, the transverse abdominis muscle,
Yeah.
And the transversalis fascia, the preperitoneal path.
Excellent, excellent, very good. So I'll point to, you can see my pointer, right? Can you see my
Yes, sir.
pointer moving on the screen? I'll point
Yes,
to a
sir.
structure and you have to tell me what it is. Okay? What's that?
The preperitoneal.
Recording in progress.
What is that? I've just marked it. Work it out. Is it midline or lateral?
It's a midline.
So what do you find on the deep side of the midline of the anterior abdominal wall? I'll give you another hint. It's in the epigastrium.
The linea.
Not the linea alba. This is the linea alba, okay, where
Okay.
the tissue meets, the anterior and posterior rectus sheath meets. That is linea alba. What could this be on the deep side? You want to have a go, Mahati?
Falciform, sir.
Correct. That's a falciform ligament. Okay. So here is what do you think this is? This is in the epigastrium and this is in the hypogastrium.
Yes, sir.
What is this structure? Anas. Urachus, correct. And what is this? It's a medial umbilical ligament, okay? Obliterated umbilical artery. So what is important for us to understand is that the anterior abdominal wall, as you have mentioned, this is the skin, subcutaneous tissue, anterior rectus sheath, rectus muscle, posterior rectus sheath, transversalis fascia, peritoneum and extraperitoneal fat. The muscles are the external oblique, internal oblique, and the transverses. The fascia of internal oblique splits into two, goes on either side of the rectus abdominis and meets again in the midline, meets up with the anterior sheath and the posterior sheath, which is formed by the transversus abdominis and the split portion of the internal oblique, and all of them meet in the middle to form the linea alba. Okay, and inferior to the umbilicus you have the arcuate line, and inferior to that, there is no posterior sheath. All the three aponeurosis of the three abdominal vessels, muscles go in front of the rectus and form the linea alba. Linea alba is complete anyway, but the posterior rectus sheath is non-existent below the arcuate line. And the problems with this are what gives you the two conditions we're talking about, which is the divarication and hernias, okay, abdominal hernias. I have restricted myself to large abdominal hernias because that's what the area of interest controversy is in these days. So, Ines, what do you think a divarication is and how does it differ from a hernia?
So, divarication is it is basically when the linea alba is stretched out. That is
Okay.
what is a divarication, sir.
Yeah.
And this is without a defect, without a facial defect. That is what
Okay.
a divarication is. Whereas in a hernia, you have like a defect in the surrounding abdominal wall.
Yes, correct. There's one other important distinction between the two. Can you think of what it is?
So, like, divarication is always in the midline, and like in terms of location, sir,
Okay.
hernia can occur in like any point of weakness in the body, sir.
Okay. Anything else? More important than that? Indicate. There is something that is always present in a hernia which is not present in a divarication.
Sac, hernial
Correct.
sac.
Correct. Okay, that's all it is. Diastasis is also called diastasis. Divarication is also called diastasis. And it is characterized by an expansion or stretching, as you said, or a widening of the linea alba. And the important thing is there is no defect. There is laxity, no doubt. No defect, no sag. That's the important thing. Okay. So for you to say something is stretched or widened, you must know what the normal is. Likit, you want to have a go at what a normal width of a linea alba is? And when generally you would call it a divarication? Can you unmute yourself, please? It doesn't seem to be either hearing or not there at all. Samir?
Yes, sir. So normal width will be around 1.5 to 2 centimeters.
Okay.
Is there any like interrectus distance more than 2 centimeters will be diastasis rectus?
Yeah, generally okay, but is it 1.5 centimeters all the way through?
So near the xiphoid, it will be around average of 1.5, sir. And below.
Where do you think it's the widest normally? Okay.
Just above
Below
the
arcuate, it will be
umbilicus.
widest, sir.
Yeah. Unless you've really studied about it, you wouldn't know. I agree. But here is a study which has looked at 150 nulliparous women. It's important to you. If you're dealing with women, it must be nulliparous women. Okay. Otherwise, you can have a stretching of the linea. Ultrasound assessment. It is actually the narrowest below the xiphisternum. It's not 1.5, but half of it. That's the average, mind you. There is a variation in that also. But it is widest about 3 centimeters above the umbilicus. And it's not very wide below the umbilicus. It's only slightly wider than below the xiphisternum. Okay. But anything more than 2 to 2.2 centimeters is considered abnormal. Okay. So I would accept 2 also as you said, Samir, I would accept that definition. But this paper suggests 2.2 millimeters as being abnormal. That's based on the average width in the normals. Okay. So where do you think you get the divarication in relation to the umbilicus? Karthik, you want to have a go? You must have seen clinically. Where do you think you get it?
So mostly we see above the umbilicus, sir, most
Yeah.
common.
Yeah, correct. Superior to the umbilicus.
Superior to the
Right? I agree. Any guess with percentages? Wild guess?
Maybe 20 to 30% above the umbilicus.
Not true. In fact, if you'd asked me that question out of the blue, I wouldn't have known. But because of this presentation, I read up about it. And this is your statistics. Okay. It's very variable. One can't say it has to be only here, but you're right. A large majority are at or above the umbilicus. And a small minority of about 11% is below the umbilicus. All right. So one would think, why is this clinically important? Karthik again.
So clinically, we have to differentiate it from the true hernia.
Yeah, the simple message is if you have a lump inferior to the umbilicus, don't jump to the diagnosis of divarication. It's more likely to be a hernia. Okay. The way you treat these two are different. That's why this is important. Okay. What do you think are the risk factors for getting a divarication? Pavitra, you want to have a go?
Yes, sir. Obesity,
Mhm.
then multiple previous surgeries, and
Surgeries for divarication? I
not
wouldn't
for
agree.
divarication, sir. Previous
No, but
surgeries, previous abdominal surgeries that causes the risk
for
factor of.
divarication? No, that's for hernia. I agree, not for divarication.
Okay, sir. Postpartum females,
Pregnancy, yes.
pregnancy,
Yeah.
anything that causes raised intra-abdominal pressure, sir. Like
Correct.
chronic
Chronic
cough.
straining. Yeah,
Yes,
chronic
sir.
straining. These are the three well-recognized risk factors for divarication. Remember, we're not talking
Yes.
about hernia, we're talking about divarication.
Okay, sir.
So, okay, you continue. Nikita, I haven't given you any work today. What do you think are the salient features of divarication? Always remember, we are trying to differentiate it from a hernia. Okay?
Sir,
Clinically, yeah.
most of the times it is asymptomatic, sir. In that there is only cosmetic, there's a bulging appearance.
There is a bulge. Okay, agreed.
But in symptomatic cases, there will be pain and backache.
Agreed. Backache is more important than abdominal pain in a
Yes,
divarication. Agreed.
divarication.
Okay.
And
Is there anything that you would qualify about the bulge? How would the bulge look as compared to a hernial bulge? A hernia also is a bulge.
it's a diffuse bulge which is actually seen on head raise or leg raise, sir.
Okay. You want to define the shape of the rig? So I gave you the answer. Shape of the bulge. Yeah. Okay. It's yeah. Head raising gives you a ridge rather than a globular swelling. You would expect a hernia to be more globular, but in a divarication, it looks like a ridge. And also, it's important, this one important thing to know is 70% of these weaknesses of bulges after a pregnancy settles down in a year's time. So if you see somebody soon after pregnancy with a little bulge, don't jump on it. Ask them to wait a year and see what happens. Okay, even if they have some degree of feeling of flabbiness or low back pain and all that, you can assure them and give them some conservative methods. We'll discuss it later. Do that, and that should help them. So important that you do not jump to the conclusion of active, particularly surgical treatment soon after pregnancy, soon after delivery. Okay, that is the main point that I would like to stress. What investigations would you do, Samir? You see a patient with divarication in the outpatients, what would you do?
So it is a clinical diagnosis, sir, and
correct. Very good.
If at all patient is symptomatic, we can like ultrasound will help us in knowing the interrectus distance and plan.
Yeah, I think you're right. So probably none. If you see somebody with divarication, complaints of, as Nikita said, a cosmetic defect, you would probably do nothing. I said, reassure them with a divarication, send them home. But if they're very symptomatic and you're contemplating surgery, you will have to do the routine pre-op workup like routine bloods, ultrasound abdomen, and get the medical fitness done. Okay. What would you do with the ultrasound? What specific information are you looking for? Samir, yeah.
Sir, first we have to look if there is a concomitant hernia.
Okay.
And
Good.
Then the ones like the
Any
interactive
other
distance.
associated problems? You know, you may have
Yes, sir.
gallstones.
Sir.
All right. Combination. You may have gallstones associated with it. Not associated, but coexistent with it. That's a more appropriate term. Gynae, pelvic problems in women, and ovarian cysts and fibroids and things like that. That's what you're looking at. Okay. Mahati, are you following what we're saying?
Yes, sir.
You are. Any questions or doubts so far?
No, sir.
No. All right. So, as I said, it's not often that we recommend surgery for divarication. Conservative treatment is the pillar, the strong pillar of treatment. What would you do? Likith.
Yes, sir. Regular exercise, sir,
Okay.
to strengthen core muscles.
There is a bulge, no? So what would do to contain the bulge?
Like abdominal binder will
Correct.
applying some
So
binder
start
support.
with that first, yeah, so that you're hiding the bulge basically. Okay. Then exercise. What exercise would you?
Like strengthening core muscles and.
Okay. What are core muscles?
Like this rectus and abdomen.
Okay. Only abdomen? Back is not included in core?
Back.
Very much.
Yes, sir. Yes.
Core is very much included. Okay. So strengthen the core muscles. What else is a problem? When the abdomen is bulging, what else is a problem? Okay. So these are the classic things that you do. An abdominal twist, a reverse sit-up, which is so-called abdominal crunches. Okay. Head rising, leg rising, crunches, and a posterior pelvic tilt, or what's called the gluteal bridge. Okay. You look up these things, these are all readily available. I wanted to put some pictures, but I thought it would take too much time to explain these exercises. But remember the names of these exercises. It is important to do these, okay? And aerobic exercises to reduce the weight. Most of them, as we said, are obese. So aerobic exercises help them with reducing the weight, which is an important part of your treatment. Okay, but there is a concept of a deep core. And how many of you know about the deep core? Anybody knows without reading this slide? What is a deep core? Anybody? You don't know? I'll explain it. Okay.
No, sir.
Nobody. Okay. So the concept of a deep core goes one step deeper than the core group. You mentioned about the core. And essentially, it means that the abdominal viscera is supported by the abdominal muscles, the back muscles, and also the pelvic floor and diaphragm. Okay, that's the thing. You remember that if there's divarication, the diaphragm comes down and its efficiency goes down when it descends. And of course, there may be associated pelvic floor weakness apart from in multiple para women, apart from the weakness of abdominal muscles, pelvic floor weakens as well. So they have a higher incidence of prolapse of the rectum and of the bladder and the uterus. So the concept of the deep core stability is first put a tight wrap around the abdomen. You can have a tight corset, for example, and then do the plank and the isometric abdominal contraction. For the back muscles, it works on both the back muscles and the abdominal muscles. But this is the addition. You must give them something like a Kegel exercise for pelvic floor contraction and diaphragmatic breathing. Tuck your tummy completely in and ask them to breathe. That activates the diaphragm. So the theory here is that this core or the tube, all the muscles forming this tube are exercised in a formal manner And when you do a deep core program, it's also borne out in randomized trials where the deep core significantly reduced. They actually measured the interrectus distance after 8 weeks of this exercise compared to the conventional simple core exercises that I mentioned previously. If you do that, not only do you reduce the interrectus distance, but also improve the quality of life. So this is important to understand that only abdominal exercises is not enough. You should try and teach them the deep core stability. Okay, what would be the indications for surgery? A small minority need it. The series are very variable, varies anywhere between 10 and 30%, depending on the unit who recommend it. But what would be the general principles where you would recommend surgery? Minus?
So first for cosmetic purposes, if the patient wants it for cosmetic reasons, in
Okay.
those
Would you do that
conditions.
first?
No, first try for the conservative management, and if that is failing,
You would put it last on the list, but what would be the indication?
pain. So despite weight loss and
Pain
everything,
where?
the back pain, severe
Back pain.
back pain.
Intractable back pain that's not getting better. Okay. What else?
And if related to that, sir, like if they have stress incontinence or
Yeah.
yes,
Coexisting
so sir.
ventral hernia is the main thing.
Okay, sir.
Okay. It's known
Yes, sir.
that when there is a ventral hernia with a coexistent rectus, divarication, I mean, if you repair only the hernia and leave the divarication, then the recurrence rate of that hernia repair is high. So there's a coexistent hernia. So you would do the second two in my list as the main indications. But I put it first there because if you look at the data of divarication repair, most of the time it is cosmesis. It is done for, it's not done for severe back pain or coexistent ventral hernia. Most of the time it's done for cosmesis. And so that's why I put it first. But if you look at it logically, okay, I think you should have a good period of conservative treatment before you recommend surgery for cosmesis. What are your options? Likit?
Yes, sir. Laparoscopic plication of the recti.
Okay. See,
Like
everything can be done open,
open.
laparoscopic and robotic. So let's not get into the complication of whether it's open or laparoscopic or robotic. That's true for all operations today. So what would be the principle of what you do, whether you do it open or laparoscopy, we can discuss later. What are the things that you would do?
Like first is plication and plication
Okay.
with mesh.
Correct.
Mesh repair.
Correct.
And abdominoplasty
All right.
surgeries.
For all divarication, you would do that?
No, sir. Depends on the patient.
Okay. So basically, you're looking at plication with or without a mesh and a repair of a concomitant hernia, which if you find it there. Okay. Now there are so many things. As I go along, I will deliberately confuse you with a million names. Okay. Here, the commonest operation done either by laparoscopy or by open method is this is a stretched linea alba. You just plicate it. You can put a mesh either below or above, onlay, sublay. You can put it retrorectus. You can put it extraperitoneal. Plane is probably unimportant other than for onlay mesh. If you put a mesh over it, in the subcutaneous plane, just superficial to the anterior rectus, it's not recommended. But otherwise, you can put your mesh anywhere in the depths. In addition to your plication. And of course, you must have heard of this word SCOLA, subcutaneous onlay laparoscopic approach. And the reason I mentioned it, it is very, very commonly mentioned, a million YouTube videos on that, but it is the less preferred onlay mesh method that they use there. So plication may be all right. Okay, dissection and plication may be all right, but they use an onlay mesh, and that really is not the recommended plane for the placement of the mesh. And here you can see a similar thing, application. You can see that, as I mentioned, the previous picture, it is in the intraperitoneal plane actually. An intraperitoneal mesh, it could be extraperitoneal but deep to the posterior rectus sheath. Here it is retromuscular, which is anterior to the posterior sheath, but posterior to the rectus muscle. So these are the various options that you have. But suffice it to understand at your level that you do a plication, that is the primary requirement. And you can also have a double breasting. That's one other option that people have described. And preferably put a mesh to strengthen the abdominal wall. Okay, and there's another technique called the Chevral technique, where just like you use we talk about component separation later. There's a similar thing of component separation here. You use a cut part, the medial cut part of the anterior rectus sheath, bring it together and stitch it. And you stitch it with an overlap so that it is very narrow, and place an onlay mesh to strengthen the anterior rectus sheath. Okay, it's called the Chevral technique. That's another technique that you can use. And the standard Ristopa, you know about it, just like you use a wide, that is in the extraperitoneal plane, just like you use a wide Ristopa for bilateral hernias, as it has been described, as you know. Inguinal hernias, hypogastric hernia, they all use the same thing. Here also you can use the same technique and put the mesh in the extraperitoneal plane, along with either the plication or an overlapping or double breasting of the widened linea alba. Okay, are you with it so far? Any questions or doubts? You can have combined methods I mentioned about. That's with a hernia. These are all the combinations that you can do. You can do a hernia repair with it, and if there's a big sagging abdomen, you can do an abdominoplasty with it. You can do a liposuction. And of course, if there is a gallstone or a fibroid or a uterine cyst or whatever, you can deal with that as well at the same time. That's not a limitation. Questions, doubts?
Sir, just
Yeah.
one small doubt, sir.
Yeah.
Sir, in all the techniques described, we are seeing plication being a part of all of them. Where is the technique only the mesh is used, sir? Like without plication, can only mesh be used for repair?
It cannot be used at all because you're not narrowing the linea alba, and the ridge continues. Apart from plication, the only other thing you can do is just bring the two ends of the rectus together. Okay, I'll show you in a picture that I have. And it's like keeling. Okay, the widened linea alba is buried, and you bring the two edges of the rectus together by suturing. It's as simple as that. You got that?
Okay. Yes, sir. Yes, sir.
The linea alba is 2 centimeters apart. You mark the medial edges of the two recti. Okay, and just stitch it up like you do keeling in an umbilical hernia repair, all the way through. I'll show you a picture of one of the things that I've done. That's an option. And as I said, the third option is that you can do double breasting. You can cut the linea alba, which is very, very wide, and put one layer below the other, the cut edges, and then stitch it up. That will also narrow. So some degree of narrowing of the linea alba is required. Some method of narrowing is required. Otherwise, just putting a mesh will not be good enough. Okay. And here is a case in point. You can see that there is no hernia, but this is one edge of the rectum. You can see my pointer, right? Yeah, this is one edge of the, let me choose. Yeah. As you can see, and go up there. This is one edge of the cut rectus. This is not cut rectus, the stretched linea resulting in two edges. This is the wide rectors that you have. So when I said you bring the two ends together, what I'm saying is you pick one stitch here and put the other stitch here and then stitch it up. So when you do that, this part of it gets stuck underneath like this. You understand? These two come together. This comes here and this comes here. Are you with me?
Yes,
And
sir.
the widened rectus just goes into the abdomen. If you look at it in a CT, then it will look like another falciform ligament, as it were. Okay.
Okay.
So it just
Yes.
gets in like that, gets tucked in, and this is one way of doing it. That's quite a recognized method. I don't know whose name goes after it, and this is exactly what I've done here. The big divarication. All I've done is the two edges of the rectors are stitched together. So you have a very narrow midline. So if you take a cross section at this level, for example, at this level, you will find the whole thing coming down. And I've done an abdominoplasty with it. And always when you do an abdominoplasty, you must have the option of resighting the umbilicus. I won't go into the technical details, but you'll find that the umbilicus is very inferiorly placed in these people with who need an abdominoplasty with an apron. So you got to resight the umbilicus to its supposedly normal position to make it cosmetically good. Otherwise, if you do the whole thing, abdominoplasty without resighting, the umbilicus will be suprapubic in location, which is very, very ugly. Or you will have no umbilicus at all. That's a valid option. You can take off the umbilicus. But if the lady insists on an umbilicus, you must resight it. So that's one possibility. And of course, I should have okay, let's finish it off like this. You have complications like in anything else, you will have complications. Seroma is the commonest. It's the commonest complication. Hematoma, you can have infection of only subcutaneous tissue, infection of the mesh, which is a big problem. A recurrence rate of around 5%, but some series say there is no recurrence at all. If you have an abdominoplasty with it, skin flap necrosis can occur. Remember, all these sometimes can be very long operations. And so DVT and pulmonary embolism are not uncommon. So you've got to give them prophylaxis with early mobilization. And all said and done, there will be a pressure increase in the intra-abdominal pressure, even with divarication and splinting of the diaphragm. And you must start chest physio. More so if it is an open operation, but even in laparoscopic operations, it's good to give them chest physio. Okay. Any questions or comments on divarication?
So if the divarication is quite large, like maybe around, like it was shown in the CT, any role of removing a strip of the linea alba and then approximating it, or you just bring it closer?
No, removal is really not required. You can always stitch it in and tuck it in, like a keel, as I said, or you can cut it and overlap it, or you can placate it. That's good enough. Actual removal is not recommended, not required. So you'll achieve the same thing even without removal.
And so drain placement, because seroma is
subcutaneous
you
drain placement. Yeah.
Okay. Yes.
Yeah. Always do that. I always do that because particularly if you have an abdominoplasty, there's a large area of dissection. So it's important. In large divarications, there is quite a lot of redundant skin. So you will have a subcutaneous space in spite of excising the skin. So it's good to have a subcutaneous drain. Yeah.
Sir, in case
Do you
of
regularly?
Sorry?
Sir, in case of very wide divarication with a very thin linea alba, and if you're trying to plicate it and if it is cutting through, can we just get over with placing a mesh and not plication? If it is cutting through when we're bring it closer.
Yeah, you can, but it will be less effective. It will be less effective because somehow you've got to get the two recti together.
Yes,
You've got to get it
if
to
it
the
is
midline.
cutting through, then do we have any other
Doesn't really
option?
cut through so much. I've never felt it, Sanya. I've never had a situation where it's so thin that it cuts through. You can always placate it. That's not an issue. But definitely you'll need to reinforce it with a mesh if it's thin.
Sir, in fact, if it is thin, it is easier to approximate
than
when it is
Okay.
thick.
But
It will not cut
Sanya's
through.
question was it may not hold your stitch at all. I don't
Yes,
think
Correct. So
it will be that bad.
anyway, we'll be incorporating the mesh in those scenarios after
in them.
placating.
Yes, sir, yes.
Correct.
Okay.
Correct. Yeah. Okay, so we move on to large ventral hernia, the second part of our presentation. Oh, I'm really going slow. Yeah, okay. Now, any ventral hernia, not necessarily large ventral hernia, we need to, today's standard is EHS classification, European Hernia Society. All right, like Likit, you know what it is? Are you familiar with it? You have to, even in your operation notes on ventral hernias, you must mention it nowadays. Are you doing it in Sagar?
Yes, sir.
You are?
It's
Are you
based on
classifying your, when you write your notes? No? Yes?
no, sir.
No, I
We are
think we
not
should.
mentioning, sir.
Pavitra, I think we are also not doing it, but we must. I think
Yes, sir.
that's an
Yes.
important thing. Okay. So
Yes,
you know what a AHS classification is. Pavitra, you want to have a go at it?
Yes, sir. So basically, it's divided as midline and lateral. So midline is according to the anatomical locations. So we go just below the xiphisternum, and then we can go epigastric or supraumbilical, then umbilical, then infraumbilical, and suprapubic.
Yeah.
And then lateral also, it is according to the anatomy. First is from top to down, again subcostal. Then you have the flanks or the lumbar region, then the iliacs, and then I think I missed flank,
Yeah, it's
iliac,
okay.
and
Yeah.
then
That's
yes, sir.
okay. I don't expect you guys to mug it up. Yeah, go on.
Yes.
Yeah. Anyway, you have to refer to this.
Yes.
And one is the location. So you must say it's, you know, if it's an umbilical hernia, it's an M3.
Yes.
Okay. If it's an epigastric hernia, it could be either M1 or M2.
Okay,
And you
sir.
have to then refer to the size.
Size.
Okay?
Yes.
That's the way you describe it.
Yes.
It is an M2 W1 means an epigastric hernia
Yes,
which
sir.
is less than 4 centimeters. Okay,
Okay, sir.
that's
Yes,
the way you
sir.
must do it. It's good to do that because we can standardize our terminology.
Yes, sir.
And the next thing is when you have multiple hernias, what do you consider as the length and the width? That's the next important question. Not always you get one defect, no, so that you have to mention the width and the length. If you have multiple hernias, what do you do? Karthik, Sanya, anybody?
So which is
important.
The
Sorry?
largest one, sir.
Yeah, sorry.
Largest one we consider as the main, sir, or
Good guess, but wrong guess. Okay. So the recommendation EHS is you must include the whole length, not the largest one. Can you see? When you have 3 defects, for example, here, the length must be given as the whole length and the width must be the whole width from the right lateral edge of the right-sided hernia to the left lateral edge of the left-sided hernia. Okay, that should be given as the width. That is the recommendation. Okay, and there is logic in this because the mesh you use, sometimes you use a single mesh to cover all the defects, right? That's our standard. So that when you measure that, if you give a 5 centimeter clearance all around, this is the measurement that you have to take into account, not the largest one. That's why this is the logic behind this recommendation. Okay, so this is, I just wanted to tickle your brains about EHS classification of ventral hernia. Please, all of us must start following this. We know it, but I was lazy. I was not insisting on it, but I think we should start doing it. Okay, right. Now we go to the large ventral hernia. What is a large ventral hernia? Karthik?
So when the hernial defect width is of more than 10 centimeter, we call it as a large ventral hernia.
Okay. Is there any other definition? That used to be the definition earlier. In my early days, 20 years ago, perhaps, or 15 years ago, not my early days, yeah, up to about 15 years ago from my early days, that was the definition. Is there anything else much more logical, much more physiological now?
Now we call it as a loss of domain.
Correct. All right. Hernia with a loss of domain is a large ventral hernia. So it leads to the next logical question. What is loss of domain? Go on, Karthik.
Sir, where there will be a more than 20 to 25% of the abdominal viscera which hides outside the abdominal cavity for a long duration, sir.
Yeah, that is about calculation of loss of domain or for the definition. But what do you think are the main issues in a loss, in a loss of domain? What would be the things that concern you?
When we reduce the content in the loss of domain,
yeah, it's now described under what's called qualitative and quantitative. Okay, it's not just the volume. Quantitative is the volume. There is a big problem with the quality. And what is the quality we're talking about? This is the quality we're talking about. Okay, please note that the abdominal muscles shrink and retract. They also become fibrosed and lose its elasticity. Okay, and so what happens is that the core that supports the abdominal viscera that we talked about earlier, the function is lost. So earlier we used to bother only about the defect and bridge the defect whichever way we wanted, put a mesh and be done with it. But now the thought process is that you must somehow restore the physiological function of the affected muscles. All right, they lose the memory and they don't work the way they should to support the viscera. So something else must be done to support the viscera well. So it's not a purely anatomical repair, but a serious attempt to restore the physiology of the abdominal muscles. All right, that is the philosophy of abdominal wall reconstruction. And also the quantitative thing that we mentioned about, 20-25% that you said. What happens is that the abdominal volume, reduces significantly. And so if you force the viscera back into the abdomen, you end up with abdominal compartment syndrome. And you can also have a flattened diaphragm, which can give you respiratory problems. So something must be done, again, as you said, to restore the dynamism in the abdominal muscles. Okay, that is the philosophy. Now we come to what you were saying, Karthik, and that is about determination of the loss of domain. How do you calculate or scientifically say there is loss of domain? Likit?
Yes, sir. There are two indexes to calculate.
What is the minimum investigation required to calculate this?
Like we compare the volume of
investigation required to compare the volumes.
CT scan, sir.
CT. All right, that is the minimum requirement. You can't do it with an ultrasound, properly at least. Yeah. So CT is required. Then you proceed. Yeah. What do you do? What are the volumes that you're looking at?
Like volume of the hernia compared to the volume of the total abdominal cavity.
Okay.
If there is greater
what is the total abdominal
20%,
cavity? What is the total abdominal cavity that you're talking about? Can you remember the names of these? There are two main ways which it is described. There are many, but these are the two main ones.
Like other than hernia.
Yeah. Okay. You have to understand certain volumes that are mentioned in this. One of them, total peritoneal volume, hernial sac volume, abdominal cavity volume. These are the three things that you have to know. The commonly used ratios are the Tanaka and the Sabag. Tanaka method is this. Okay. The loss of domain ratio is hernial sac volume divided by the abdominal cavity volume multiplied by 100 expressed as a percentage. So you look at the cephalocaudal and anteroposterior distances of these volumes. This is the abdominal cavity volume. This is the hernial sac volume. You measure it with, of course, nowadays it is software, but you can also have a formula, get the volume. So you have the LOD ratio, which is hernial sac volume divided by abdominal cavity volume expressed as a percentage, as I said. And this is your actual index. If it's less than 10%, it's a small hernia. Primary suture or mesh or whatever you use is fine. 10 to 20 is borderline, but more than 25%. If this LOD is more than 25, it has a higher risk of everything, recurrence, loss of function, abdominal compartment syndrome. So you have to do some form of component separation. We'll come to that later. Okay, component separation is the method by which you restore the physiology of the abdominal wall muscles. Okay, the other one is the subarg method. What is the subarg method? Anybody? Nikita?
Sir, here the calculation is done to the hernial sac volume to the total peritoneal volume.
Yeah.
So the ratio changes here, sir. It goes from
So what is
20%
considered
to 25%.
significant? 20%. You're right. Okay. Total peritoneal volume is the hernial sac volume plus the abdominal cavity volume, and the threshold is considered 20%. If the hernial sac volume is more than 20% of the total peritoneal volume, then you have to have some kind of an abdominal component separation. So these are the two main ones. As I said, there are others also. If you look at the literature, don't bother about those. These are some of the examples of the cases that I have done. I've just put a couple of pictures here. Look at this recurrent hernia. This lady had 4 attempts at hernia repair. It had come back with a vengeance, with a large volume. Look at this, another hernia coming here, there, with a large apron, fatty apron. So this lady had a component separation along with an abdominoplasty. When you opened the abdomen, this is the way it was. Everything was outside the abdominal cavity. All right. And so that, when you repair this and put it back, as I said, there is an issue. So what do you do with this? You have to prepare the abdomen to take this content of the hernial sac back into the abdominal cavity. So in some way, you have to expand the abdominal cavity before you actually do the operation, unless you're dealing with a potential strangulation where you take the risk in going. So what are the methods where you can increase the abdominal volume? You've got the answer for one of them here. Pavitra, you want to have a go?
Yes, sir. So preoperatively, they inject botulinum toxin A that causes relaxation of the muscles, sir, so that it can expand later on. So then once we inject
No,
this,
it doesn't expand later on, it expands then and there. Yeah.
They say it takes 3 to 4 weeks for the action of this injection on the abdominal muscles.
It's given that part of time, but it starts relaxing. Yeah.
Okay, sir. And then we give 30 units per setting. The abdominal muscles, and then after 4 weeks is when you can actually go and operate.
Where do you give it? You inject it? Where do you inject? Is it only 30 units? I don't think you got it right.
There are 5 points, sir, actually. One is external oblique aponeurosis. There are 3 points. And one is between, not sure, sir, subcos.
Okay, you're
lateral,
sure now.
There are 5 points.
Yes. I've got your picture there, okay?
Okay,
40 units into the external oblique and the internal oblique. You don't put it deep into the transversus, because that's where you want the maximum expansion. And you do it by ultrasound guidance if you want.
Okay,
You can use 200 units of. Okay, there are 3 points, as you can see, lateral to the linea seminulare, the lateral border of the rectus, one further out there.
Okay, sir.
And you have 3 into 2 into 2, total of 12 injections, total of 200 units. Okay, that's what you do.
Okay.
And then you give it either 2 to 4 weeks before surgery, as you said.
Yes.
And hopefully it will work. I've never used it because I use the other method and it works extremely well. What is the other method?
Progressive pneumoperitoneum
What do you do with
preoperatively.
that? What do you do with that?
So progressively, you create pneumoperitoneum
Yeah.
through a silastic tube at the umbilicus, like how we do for all laparoscopic procedures. So that gradually you're increasing the abdominal content volume. So that once when doing the surgery, there is enough expansion and there is no compartment syndrome when we do the surgery.
Yeah. I use an actual peritoneal dialysis catheter. Okay. I don't put it in the umbilicus. I put it in the left upper quadrant usually.
Okay.
Because it goes through the muscles and sticks better. In the umbilical area, sometimes if it's a very narrow, very thin umbilicus or a very thin linea, then you can also the other problem is you can have leaks around it. It's air after all. Okay.
Yes.
And this is what you do. I use peritoneal dialysis catheter with or without ultrasound guidance. You give a little bit of air, just 300 ml. MY is a typo there, ml it should be. 300 ml of air, and then take an X-ray if you want. Make sure you're in the peritoneal cavity, and then you put about 800 to a liter of air every day. You ask them to come every day for 7 to 10 days. I don't usually check with a CT. You can see the obvious distension. And this volume also is a ballpark figure. I put enough in until the patient feels I'm uncomfortable. They get so much bloating that either they get a bit of a shoulder pain with diaphragmatic irritation, or they say I'm very distended, I can't breathe comfortably. When those two things happen, I stop pushing air in. And usually it's about a liter a day. And then you do it for 7 to 10 days, you get a good expansion. You can see CT evidence of it, There's this kind of a thing. You can see the amount of air that is there and the volume that increases, volume of the abdominal cavity that increases. I've never used botulinum. It's also expensive, and I don't think it works as well as the pneumo. Pneumo is a more efficient and a more and a less expensive method. Okay. Now, the whole purpose of this crowded slide is to confuse you as much as I got confused. Okay. You can imagine, as I said, everything can be done by open method, by laparoscopic method, or robotic. The number of things that are being done is enormous. Each one gives his own name to it, and you have some 8 or 10 different ways in which these things are done. And I always say that when you have so many different ways, it means none of them is good. Really, in anything in surgery, I think every surgeon across the world is going on an ego trip and describing his own method of doing something, gives it a nice fancy name, gets a publication. But at the end of the day, we really do not have solid data that whatever is pushed in the abdominal wall surgical fraternity has any solid data backing it. That is the honest truth. Of course, people will challenge this statement of mine, but we really just don't have mature data. But I put this up to make sure that all these things exist, and you can go and look it up. There is the IEHS, International Hernia Society Guideline of 2019, where there is a mind-boggling array of procedures that they have listed. They all say that the level of evidence is somewhere B or C, never A, never a high degree of evidence. It's always in the lower realm of evidence. Okay, so what I have decided is to give you some solid idea about what should be done to get good results, safe results, and guaranteed results. In the sense, you have to keep your recurrence to a minimum. You got to keep your complications to a minimum. So what I'm going to describe in the next few slides is that method, and that's the one that I'm following. Okay, here all I'm showing is that you have a lot of confusion about where to put the mesh. You can put it onlay. This is a very nice, picture that I got from the BJS. Onlay mesh is sitting on the anterior sheath, rectus sheath. Not a good method. Avoid it as much as possible. If you have no chance of putting it in a deeper layer, then use it. But I hardly ever use an anterior mesh. The best is perhaps pre-peritoneal mesh, the green one. But you can also use, if you're doing laparoscopy, getting it there is possible. As you know, all these ETEPs and all that, you put it there. But you can put an intraperitoneal mesh and get away with it, irrespective of what everybody says. Even the latest guidelines everywhere says that it is a surgeon's choice as to which plane you put it in. Retrorectus mesh, as compared to the pre-peritoneal, is that it is sitting behind the rectus muscles. Okay. And obviously, once you go lateral to the rectus sheath, you can't call it a retrorectus anymore. You'll have to call it a pre-peritoneal, or there's one other name for it. There's one name which I don't think I've listed here. Yeah. So you got to understand that when you talk about retrorectus mesh, it can extend only up to the lateral border or the lateral limit of the rectus sheath. And so when you have to go beyond that, you will get up and you go deep to the posterior rectus sheath, and that becomes a pre-peritoneal mesh. Okay, are you with it? Any other doubts or questions? Any of these posteriorly located meshes are good. The anterior one is the least preferred. Am I clear there? Am I clear? Can you answer me?
Yes, sir.
Thank you. If you don't answer me, I don't know whether you're listening to me or whether I'm not clear. Okay, so answer me. Quickly unmute and say and answer me. Yeah. See, that is the basic concept. Yeah, go on.
Sir, regarding the botulinum injection, sir.
Right.
Are we injecting into the muscles only? No, so like into the external oblique, into the internal oblique, not between the layers, into
Correct.
the muscle
Into
direct.
the muscle. Into the muscle.
So into the three muscles, sir, because
You're not using the third one, because all it means is that the ones you want to relax are the internal and the external oblique, because most of the time you'll end up with some kind of a tar, transversus abdominis division. So you don't bother whether it's tight or loose, because you're cutting it actually. So better to do the anterior to give you get the maximum effect of distension. That is the logic behind it. Yeah.
Then how it became 12 injections, sir, if you're not giving it in transverse abdominis? It's 3 on one side, 3 on other side.
Three on one side.
3 on the other side.
3 on other side. 2 muscles on each side. 6 muscles on each side. So it becomes 12. Got that? No? 3 sides.
Yes, sir, yes. Muscles. 2 is the other 2 muscles.
2 muscles.
Okay, sir.
3 into external oblique and 3 into internal oblique on each side.
Yes, sir. Yes, sir.
On 2 sides becomes 12.
Yes, yes. Thank you.
Okay. Okay. So this is about I'm giving you general principles, and then I'll tell you the specific operations later. Here, as I said, the principle is to decide on where you put the mesh, depends on the convenience and the kind of dissection that you do. The next thing is to close the defect. Okay, if you're closing the defect, then you can either use a tack or a linear stapler. And to me, the last one is the commonest. I don't close any defect. Okay, because you remember, for decades, we've been taught that you need to have a tension-free repair. Okay, when you close a defect, obviously there will be tension, unless you do some kind of a component separation. That's a different issue. Okay, so if you're doing a component separation, sure, you can use a tacker or a suture. If you're not doing a component separation, do not stitch the defect. But in these days, when you're talking about E-taps and this and that, this has been reversed. And so people are stitching it up either with a suture or with a stapler. Again, as I said, the serious evidence for either or the other is non-existent. Okay? Reconstruction. As I said, one of the commonest things is no closure at all. Or you can close the hernial defect, close only the posterior rectus sheath. Okay? Close the defect and the sheath. And if there is a coexistent diastasis, close that also. All it means, if you are getting confused about this, that is the idea. Because I think the world is confused about this. Each one does his own thing, and even the guidelines, they list all the things that have been done and say in their recommendation that everything has a low level of evidence. And so I'm telling you, you will see that when I describe the operations that I do, because I have simplified it for the sake of coming out of confusion. That will come later, in the next 10 minutes. Here, I'm just listing what the guidelines say, just to impress upon the fact that all these things are being done. And if you ask me which is the best one, sir, the answer is nobody really knows. So here we go on to our regular treatment of what we should do. You can do it by open method, by laparoscopic method, or robotic method. I prefer the open method. I'm the most familiar with it, but I must admit that it can be done equally well with laparoscopic method. Robotic, I don't think non-enthusiasts do. But as I said, if you have a large defect that is the subject of discussion today, you have to do some kind of a component separation. Two things you must do for large ventral hernias with loss of domain. One, preoperative preparation with pneumoperitoneum. Two, component separation. Component separation can be anterior or posterior. And this picture gives you in very simple terms what it means. As I said, two things to note in this picture. One is in the anterior component separation, you cut only the anterior sheath. In the posterior component separation, you cut the posterior sheath here. And the other thing of note is this. The neurovascular bundle for the anterior abdominal wall goes between the transversus abdominis muscle and the internal oblique muscle. Please note that. And when we talk about posterior component separation, we'll come back to this fact. The neurovascular bundle, I repeat, is between the internal oblique and the transversus abdominis muscle. Okay, in the anterior, because of lack of time, it's already 6 minutes past 10. I'll just go through rather than ask you questions, which may take more time. Okay, you have the endoscopic method. The common open method is what I do, open anterior component separation, and open minimally invasive perforator sparing anterior component separation. Okay. The perforator sparing means the perforators are a little more lateral. So you make sure that you're more medial in your cut of the anterior sheath, the anterior compartment, anterior sheath, so that you save the perforators, which means that you will have less problems with the skin flaps. Okay. Now, normally, I'm showing you I've used the normal conventional Ramirez method, also this method. Normally, what you do is you cut the release of the muscles happens out, the external oblique happens outside the lateral border of the rectus. Okay, the external oblique aponeurosis. It is somewhere where this cut is. It's that lateral, this is the midline. It is lateral to that. So what I've done is here, a large hernia, I have dissected the sac, open method, put an inlay mesh. An inlay mesh is in the same plane as the rectus muscle. It's not onlay, it's not sublay either. It is an inlay. Inlay mesh, you can see the mesh through here. Normally, what is recommended in the Ramirez method is is to do a subcutaneous dissection in this plane, anterior or superficial to the anterior rectus sheath, go beyond the lateral border of the rectus, and about 2 centimeters lateral to that, you cut the external oblique only. So what it does is that it helps you move the midline closer so that it reduces the tension on the mesh, or if the defect is not very large, you can even stitch the midline defect without a mesh also, even that is allowed, or strengthen it with a sublay mesh and stitch the midline over it. These are the three options. The problem with this kind of subcutaneous dissection is skin necrosis and a large seroma and a hematoma. So the one way of getting around it is to just cut this, okay, 2 centimeters lateral to the lateral border of the rectus. Just cut the skin and subcutaneous tissue all the way through, and cut the external oblique also. You can leave this wound open, nothing happens, and then maybe a couple of weeks later you can resuture it. By that time the edema would have shrunk. You get the same effect as your Ramirez method when you do this. On occasion, when I find that the patient is not very obese, I have done the classical Ramirez as well. The other possibility to strengthen with or without a mesh is to cut the anterior sheath. You call it an anterior sheath flap. You cut the anterior sheath from there and swing it over medially and then stitch it. Depending on the width of the defect, you can either stitch it end to end, or you can even overlap it and do double breasting. Both are possible. And of course, you can reinforce it further with a mesh underneath in the sublay position. That is also possible. This is the anterior compartment separation. The posterior component separation. The posterior component separation, as I said, it is important that you stay 1 centimeter medial to the lateral limit of the rectus sheath. This is where the nerve comes into the muscle. Okay, if you cut the nerve, then you end up with a weakness. You get a bulge and a higher failure rate of the hernia. So it's important that when you move it, when you cut it, to move it medially, the posterior component, it must be at least 1 centimeter medial to the lateral limit of the rectus sheath. This is exactly what you do. You've seen it. I mean, it's done laparoscopically nowadays. I'm showing it. It's not my own picture. This is borrowed from the neck, but I'm showing it in this. I've done it several times. This is a retrorectus plane. You go into, this is the posterior rectus sheath. This is the lateral limit of the rectus sheath. And so you cut at this point, okay? Don't cut too close to the thing. So cut 1 centimeter medial to like this. This is where your cut should be. When you cut it like this, you get into the plane between the internal oblique and the transversus muscle. And you'll find that when you extend it cephalocaudate as much as you want, depending on the defect size, you'll get a beautiful medial movement of this posterior rectus sheath, so that even a large gap like 10 centimeters can be relatively easily closed. Okay. My slide on the guidelines, again, I go back to the International Hernia Society guidelines. Please note, a laparoscopic repair of large hernias is burdened with a higher recurrence rate. It's being done very commonly. Because of this, and because I find that it is quite a cumbersome procedure compared to an open method, if there is a large hernia and I need to do a TAR, transversus abdominis release, I do it by the open method. Okay, both can be recommended, of course. And if you have a lateral hernia, then it has to be through an open approach, because fixation of a mesh and the dissection of very lateral hernias, remember the EHS classification, the fixation of a mesh in a lateral hernia is going to be difficult. I have done quite a few of lateral hernias laparoscopically also, but with an intraperitoneal mesh. But if I find that the defect is so close to the line of Tolt, for example, that's where the lateral reflection of the peritoneum is on the lateral abdominal wall from the colon. You need to have a 5 centimeter clearance for your defect. And so you'll be actually getting behind the colon with your mesh. It's really not worth it. So I do it by the open method and use an inlay method rather than a sublay method. Okay, so that is as far as the lateral hernias are concerned. This is a variation, but lateral hernias are a challenge. And if you want, I can have a separate discussion on it some other time. But I think at the DNB level, you don't have to worry too much about it. I don't think we'll be bothered with too many questions on that. When you come to practice, yes, you will have to have various options to deal with lateral hernias. So I think this is my last slide. What complications would you expect? Ines, want to have a go? Not there?
Yes, sir.
There? Yeah.
So, in like maybe, sir, I'm not sure, sir, actually. Like, I'm not
It's very simple. It's not beyond you. First of all, what do you think is this a small operation or a big operation?
It's a major surgery, sir. Big
Okay.
operation.
So you have large raw areas, right?
Yes, sir.
So what do you have when you have that?
So, surgical
Work
site
it out.
infection.
Yes,
So firstly,
surgical.
site infection will be there.
Right.
Apart from that,
In any hernia, there is one complication.
seroma formation, hematoma formation,
Recurrence.
and recurrence. Yes, sir.
Okay. Yeah.
And
Yeah.
so bowel injury and like
Correct.
compartment syndrome.
Then why did you say you didn't know? You got to
Like
work it out. It's all very
Yes, sir.
simple. Okay. So
Yes.
to get your complications in a comprehensive list, I keep on telling you, for anything in surgery, classify your answer. Okay, give it under subheadings. The subheadings here would be general complications, wound complications, abdominal compartment syndrome. Okay, and in a posterior component separation, you're into the abdomen. So your anterior, it doesn't happen. You got to look at getting into the abdomen and what are its problems. Okay, so here you can see in respiratory infection, DVT, common recurrence is common in all of them. Seroma, infection, hematoma. As I told you, there are big flaps, so you can have skin necrosis, compartment syndrome, denervation syndrome. I keep saying be careful, do not denervate, but you end up denervating it, cause a general weakness and the general bulge and a higher failure rate. Peritoneal tears, bowel damage, and rectus atrophy. These are the common complications that one can see, and you must be aware of it and face them. Okay? How do you minimize complications? When I told you, one of the challenges we have is to minimize these things. What would you do? How would you do it? Karthik, you want to have a go?
We'll put a drain to reduce the seroma.
Okay, good.
And
told you about infection. All right. Always putting a foreign body, particularly dental care, is very important. It's applicable to all hernias, but more so when you use these large dissections and large meshes. Okay. DM control, dental care, nutrition, smoking. I told you about respiratory complications. You want the wound to heal, so the nutrition must be good. Get a functional status. They must be able to do a good physio properly. I mentioned about the pneumoperitoneum and Botox. Use meticulous technique. And I kept on telling you about the possibility of chest infection and wound infection and DVT and PE, early mobilization, DVT prophylaxis, vacuum suction drainage. This is something which is new. We always associate vacuum suction dressings with open wounds, right? But there are a lot of papers now with good results being shown in patients where they have put a vacuum suction even on a closed wound, because they suck out the seroma, they suck out the hematoma that may form. So for the first few days after surgery, you use a vacuum suction, the results are better. So this is something that we should seriously consider, change in practice. I have not had to do it so far, but I would definitely consider it if I have done a big dissection, I would consider a vacuum suction drainage on top of a closed abdominal wound, not a wound that is necessarily left open. Okay. Thank you very much for your. I'm sorry I overshot a bit, and again, my apologies for the initial disturbance because I was doing it from the house. Any questions, comments, or doubts?
Sir, for component separation, sir, do you mark prior, sir?
No. See, it's a good question actually. The end point is that you must be able to bring the midline together. Okay, you have the posterior sheath, for example, which is far apart, 10 centimeters apart. That's a kind of standard kind of distance. After the components, when you try to put it together, it will never come together. It will keep tearing, and you have to really struggle. Whereas after the component separation, you will find that when you've done adequate component separation, it will come together without any tension. That is the measure. And for you to know if it doesn't come together even after component separation, it just means that you have got to extend your component separation cephalocordad. Okay, you have a 10 centimeter wide and a 5 centimeter long defect. So you got to go in your component separation maybe 2-3 centimeters beyond on either side of the 5 centimeters. So the longitudinal, you understand, the cephalocordad separation would be perhaps 10 centimeters for a 5 centimeter defect. You have 2.5-3 centimeters on each side. Are you with me?
Yes,
what I'm
sir.
saying?
Yes, sir.
Yeah, do that. And if you find that even after that you're not getting it together, you can go from the suprapubic area up to the xiphisternum with your component separation. When you keep doing it, it'll come together.
Okay, sir.
Yeah.
Sir, and those lateral incisions that you had shown, is it always made, sir? Is it a standard to make
No,
those?
it's actually it's a modification.
Yes.
But I do it that way because it's much easier
To
than
locate.
to undermine the skin from the midline all the way to 2 centimeters beyond the lateral border of the rectus. And it's a lot of dissection, it keeps bleeding and all that. So you can just do the lateral cut and leave it like that, And
Yes,
one of the main problems of that is post-op pain. So most of these people will have an epidural. And
so in the once you make the cuts, you're also bringing closer the subcutaneous tissue as well as the skin, right, sir?
Yes, skin, subcutaneous tissue, and the external oblique. The whole thing is cut.
But if we just go below the subcutaneous plane to reach the rectus later, then we are not bringing close the subcutaneous layer. Like,
but you'll never have a problem with the subcutaneous layer.
Okay, sir.
Yeah, it's never a problem. It'll come together all the time.
Always, yes, sir.
Yeah. The problem is only in the lateral retraction of the muscles. That has to be released. So in the anterior component separation, you release the external oblique. In the posterior component separation, you release the transversus.
Sir, any videos of you where you have operated are there?
I was disappointed that I've done quite a few, but I haven't documented it. So I decided, that I will get a video of the next one that I do.
Yes, because in the YouTube and all, not very clear.
Quite a few, no? It's not very clear.
But not very clear to understand. That's why.
Yeah, I'll try to do that. I have not really videographed my operations. I should have.
Thank you, sir.
Okay. Thank you very much and good night. I'll end the meeting now. Okay.
Thank you.
Thank you, sir.
Niranjan, I didn't ask for your comments.
Sir, it was very good, sir.
Your closing comment, your experience. You're a pretty experienced surgeon now. Your experience and what you would pearls that you give the youngsters.
I think most hernias we can probably manage with IPOM, IPOM plus. Only any hernia probably more than 6 to 8 centimeters will require some lateral. So after that, the lateral release currently I think it is TAR. So we should be well versed with the technique of either unilateral or bilateral TAR.
Yeah.
And currently the new thing which is increasing, probably in the US, the highest number of hernias are being repaired through robotic. The claim which they are telling is the pain, lesser pain because of the suturing rather than use of tackers. That is the only thing which they are claiming. So the robotic hernias are the highest number compared to lap in the US currently. That is a trend. We will have to wait and watch for the long-term results.
I don't think, honestly, I'm a skeptic. I don't think it deserves the extra expenditure that people talk about. It really is not very painful. It really is not very painful that we have seen.
Yeah, that is what in our experience. In our experience, what we have seen is it's probably for 24 to 48 hours.
Yeah.
Beyond that, it doesn't
matter. So
make any difference.
Time will prove what is sustained. What will sustain the which method will sustain the.
But that is what the the recent papers and even the American Hernia Society and all that. If you look at the numbers, that is an increasing trend, even for inguinal hernias.
Correct. Okay. All right. Good night. We'll see you then. Yeah.